I performed a classic vertical bone generation. 1 millimeters of residual bone. Crazy situation. But I place implants, sterilize the membrane on the lingual side, wash the inner part of the membrane, grafted the biomaterial in excess, and close the membrane over the top of the biomaterial. Each contour is perfectly in adhesion with the bone. We have to place several screws or tacks in order to adapt perfectly the membrane, the border profile of the membrane to the bone. I waited 8, 10 months probably, I don't remember, no, 13 months. Why? The defect was 12 months. 12 months. I waited 13 months probably because the patients couldn't come when the 12 months concluded the time of bone regeneration. 13 months before the removal of the membrane, this was the clinical situation. I reported the top of the region on the ideal line in order to reconstruct the prosthesis with the same length of the adjacent teeth. In Latin language, it is restitutium ad integrum. It's a Latin. And I removed the membrane. This is the bone. As the previous cases, in the middle, the quality of bone, no well vascularized, no well compacted, no good density, no strong, no hard. I waited. But without the periosteal contact, we cannot improve the quality of bone. We could live more and more longer time, but the bone doesn't change its quality. So, during this time, I harvested a carrot. The bone was very large, 17 millimeters, I don't remember, it's very big. And here, at the level of the last implant, I harvested this carrot. Where I harvested the bone, where the quality was worse or better, or the quality was better. I didn't harvested the bone here. I harvested the bone here, where there was a good vascularization. And then I closed the flaps again, periosteum contact. Waited 1, 2, 3, 4 months. And 4 months later, I activated the implants with the same procedure, the soft tissue management. And so I elevated a half thickness flap, I repositioned a alveolar mucosa apically, and I grafted a free gingival graft. But during this second stage, I harvested a second carrot between the last 2 implants. Do you remember which was the quality of bone in this area? Do you remember? Poor. Okay? And you can see the different position of the harvesting of the bone. Behind the first, in the middle, where the quality was very poor, the second. This is the first carrot. You can see the first carrot where the quality was good, well vascularized, good compactness, good density. Everything was better than the mesial area. So in any case, you can see, on average, 50% of residual material in white. And then two other colors. In red, the new vascularization. In violet, the new bone. 50% of new bone, no more. Shit. I waited 13 months for 50% of new bone without the periosteum activity. But if we compare the previous carrots, bone carrots, with the second carrots, wow, wow, help me, wow, wow, periosteum contact. This is biology, periosteum contact. It's incredible. This is the importance of the contact and the promotion of the bone maturation through the contact with the periosteum. But we analyze all together that I harvested the second carrots where the quality was horrible. The bone was white, no density, no vessels. But comparison to carrots, you can appreciate that there is probably 10-15% of residual material, no more. And the quantity of the new native bone is increased enormously. Good vascularization and good quantity of the native bone. And look at, what is this? Do you remember which was the surgical approach? I elevated and half thickness flap. Do you remember? Because at the same time I grafted the gingival graft. It means that it is the periosteum. And look at the zone in which there was the periosteum, how the new bone increased. How it increased the mineralization of the bone. When we speak the corticalization of the bone, what means this one? That in contact with the periosteum, the bone is transformed in a cortical layer. This is the function of the periosteum. And you can see the cortical layer that is placed externally to the bone. You cannot distinguish the difference between the native bone and the regenerated bone. Now you know that this is a case in which I regenerated 1 centimeter of bone. But if I should present this case with this cut or slice of CBCT, without showing before the defect, Probably you could think that these implants were inserted in the native bone, not in the regenerated bone. It means that if we respect the biology of the bone, we can get these results, stable results. Now, I would like to analyze the different approach that we could have in relationship with the different type of defect. We have to compare three different devices: the absorbable membrane, the non-absorbable titanium reinforced membrane, and the customized titanium mesh of new generation. New generation because the characteristic of these titanium meshes has been invented by me, proposed by me, developed by me, and now copied from each company in the world. A new paradigm. Before, we used a mesh, a customized titanium mesh with a large holes. But it was a contradiction, a biological contradiction. We used the customized titanium mesh for bigger defect, with bigger holes, and protecting or isolating the competition from the connective tissue through the using of an absorbable membrane. Crazy. Crazy. We use a barrier that had a shorter time of barrier effect relating the time of bone regeneration. Are we using a customized titanium mesh for big defect? Yes. What does mean that the time of revascularization or the time the osteogenesis is long? And it means that we have to protect for a long time the environment to be regenerated from the competition of the connective tissues. But on the customized titanium meshes, we place absorbable membrane. And this was the reason why you found the connective tissue inside the membrane. The removal of the mesh was very complicated, and you didn't manage to get the same quantity of bone that you protected with the custom. And this is the new generation, a micro-perforated mesh. The bone regeneration is regulated by several processes, all rigidly interconnected and depend on each other. But the main mechanism around which bone regeneration spins is linked to the restoration and reorganization of the vascularization. Without an adequate vascularization, we cannot have bone regeneration. Because are the vessels that transport the osteoclast cells. The osteoclast cells don't come from the bone. The osteoclast cells come from the hemopoietic field. It means that if we don't have vascularization, We cannot, the osteoclast cells cannot be transported in the site to be regenerated. We cannot activate the osteoclast activity, that is the boosters of the osteogenetic processes. So, in conclusion, you want the bone regeneration, you have to have a good vascularization of the site. And the new angiogenesis needs a development time. And the development time is measured on average in 1 month for each millimeter. It determines the time for the bone regeneration. It means that considering the long time that some type of defect need in order to obtain an adequate revascularization, long time, we cannot use absorbable membrane. Even if under the technical point of view, you can, technical point of view. But this morning, I focused the attention on technical and biological point of view. And this is the reason why the choice of the barrier has to be jointed with the biological point of view, not the technical point of view. This is a classic case of absorbable bone, absorbable horizontal defect. An intercalate cases in the lower jaw, in which we perform a well-defined design of the flap, a cutback design the posterior area, stick-hockey incision anteriorly, paracrestal, vestibular paracrestal incision with a curved incision against the teeth. I detached the flaps, and you can see that I don't like this quality of bone. I use an absorbable membrane, but I don't like this bone. It's too hard, too wide, too poor of vascularization, no cancellous bone, I don't like. But in any case, I harvested the bone with a safe scraper. I prepare the osteotomies, I place the implants after the perforation of the bone with several holes. And very, very limited defect. This one can be treated with absorbable membrane. 2-3 millimeters, short time for the revascularization of the site. And then we started with the fixing of the membrane. Why I would like to focus the attention on the fixation of the membrane? Because until some years ago, there was a common idea between the surgeon that using the absorbable membrane, you couldn't avoid to fix the membrane. The membrane was placed over the top of the biomaterial, and the plasticity of the membrane, the capacity to adapt to the shape, hydrating the membrane, was sufficient in order to protect perfectly the biomaterial. But if we wanted to get a perfect isolation between the competition of the connective tissue and the environment to be regenerated, we have to close perfectly the border of the membrane against the bone. It means that also this type of membrane has to be fixed always. Always. So I place some tacks with the pneumatic device on the lingual side, because in this area it's very difficult to fix the tacks with a hammer or inserter. But fortunately we have at the disposal this type of device, that angulated device with which you can fix in a pneumatic way the tack on the lingual side. Then I grafted the like material around the defect, and then I close the membrane on the buccal side. I place an excess of material if compared with the type of defect. I will show you with the next case how the quantity of biomaterial that we place around the defect is transformed in bone, losing on average the 40-50% of a starting quantity. It means that if we place 10 millimeters in horizontality of new material, probably we manage to get 5-6 millimeters of bone. We lose on our therapeutic street, we lose on average 40-50%. A well-compacted material below the membrane, well stabilized on the buccal side, passivation of the flap, closure of the flaps with always the same modality. The horizontal matrix sutures, first line, and the interrupted sutures, second line. Then I waited in order to activate the implants and get the adequate quality of tissue with a modest repositioning of the keratinized tissue. So, very modest defect. Very modest defect. Also, this one is another little defect. I prefer this defect than the last one, because even if the defect probably is bigger than the previous, but is placed in the upper jaw. Upper jaw has a better vascularization, reduces thickness of the cortical layer, good quantity of cancellous bone, all things that helps the osteogenetic processes. Reason for which I can use an absorbable membrane. The defect is a severe and very thin layer of bone. I have to involve 2 teeth. I place a biomaterial in excess. I sterilize the membrane on the buccal side before, and then I close the membrane on the palatal side. If we look from the surgical side from the occlusal point of view, we can see how the quantity of biomaterial that I place is more than the ideal profile of the bone. On average, the double. And then I close the flaps with the same concept, with the same philosophy, the same timing, two lines, horizontal interrupted sutures, different material, PDF dense for 0 for the top of the ridge, and absorbable 6-0 sutures for the vertical release incision. 7 months. This is the healing, but you can see, oh my God, it doesn't work, I don't know. You can see that buccally, we don't have the same convexity profile that we had at the time of placing of the membrane. This is the bone, acceptable bone, but not good quantity of bone. I can place the implant, but the significant difference between the bone that I managed to regenerate with a non-absorbable titanium reinforced membrane and this device. So in case I elevated the flap, I prepared the osteotomy with a surgical guide, I placed the implant, but look at the incredible contraction of the bone that we had in 6 months. We obtained a bone regeneration, but reducing the original bone volume of 40–50%. This was the profile, this is the profile of the bone, and this was the profile of the biomaterial, contracted. Because we lose the barrier effect before that all material has been transformed in osteoid tissue. Because the time of revascularization of the site of regeneration is longer than the time of barrier effect. And so fortunately, from the inner part, we started with the regeneration and revascularization. But then at that time, the membrane lose the barrier effect, and the connective tissue started to phagocytate the biomaterial, or create a fibro-integration. And so, I placed the implant, and at the same time, I harvested the connective tissue graft. I desepithelialized the connective tissue graft in order to graft it inside of buccal site, in order to improve the quality of the tissue, in order to support the verticality of the pillar. In fact, as you can see, I grafted buccally and crystally, not only buccally. I closed the flaps perfectly, and I waited. And now you can see that our profile is changing. It's more harmonic, the texture is better than the time when we placed the implant. And so we have to control or manage the disalination of the mucogingival line. Because with the GBR procedure, with the passivation of the flaps, this line has been moved corner. And so I elevated a health thickness flap, and fortunately, being this area on the buccal side, I didn't graft a free gingival graft, because I don't need the healing for the first intention. I grafted and substituted tissue that have a second intention healing with some limitation, the sickness, for example, but that guarantees a good color. And so I grafted substitute tissue, activated the implant, and stabilized the substitute tissues. 1 week later, good healing. The temporary crown, the modification of the temporary crown in order to create a scallop and the symmetry of the scallop with the adjacent tooth. And from here, this is the starting case. We arrive here. And then, with the prosthetical restoration, we finish this way. Absorbable membrane. We can use this barrier also on the aesthetical field only when the bone defect is modest. And better if in the upper jaw. Then we can apply this device in larger cases or more severe cases, like this, for example. And posterior lower jaw, where there was a residual implant that we decided to maintain in order to support temporary bridge. We elevated the floor in a lateral way, with a lateral approach. And in the same way, I clean the implants that has to be removed, of course, but temporarily I want to maintain in order to support during the GBR procedure the process. And so I clean very well the implant and I perform the osteotomy of the lateral bone, lateral wall, elevated the Snyderiana mucosa, protected the Snyderiana mucosa with absorbable membrane, grafted the sticky bone inside, and placed again the bone wall outside of the biomaterial. Covered all with the fibrous membranes, and then place at the same time another implant posteriorly that allows me to remove the hopeless implant, but at the same way support the temporary crown during the long time of bone regeneration. And so this is the day of the bone regeneration. You can see how the bone wall is perfectly in addition with the biomaterial. We removed the implant. We performed the bone regeneration with absorbable membrane. We created a pocket inside which we grafted the biomaterial after the removal of the implants. We grafted the biomaterial in excess, and when we fixed the membrane on the palatal side, we left open a window or an access laterally from which we can improve the grafting of the biomaterial. And through this window or access, we continue to graft the biomaterial and to move the biomaterial corner. Then we completed the closure of the membrane, a good width. You can see that we managed to get a good horizontality and sometimes also verticality with the absorbable membrane. Through this procedure, the refilling of the biomaterial. We place some fibrous membranes, close the flaps, respecting this same protocol, horizontal matter sutures, and interrupted extrusion, and at the same time we activated the implants. And this is the regeneration of the bone, a good quantity of bone with an absorbable membrane. But we are speaking, relating horizontal bone defect in the upper jaw, not lower jaw, in the upper jaw. But in any case, even if the quality is acceptable, if I have to be honest, I don't like this quality. There is a granulation, some granules of biomaterials is not perfect. And we treated an horizontal bone defect in the upper jaw. In any case, we placed the implants with a surgical guide. We took the impression, the surgical impression, with the scan body of the implants placed posteriorly in order to organize the temporary crown, the temporary restoration. That will have support posteriorly from the implants osteointegrated and anteriorly, I don't remember, probably with the tooth that was prepared before. These are our implants. These are the finalization of the job after the soft tissue management. I can accept the results, these results, but I am sure that if I would have used a non-absorbable titanium reinforced membrane, probably the results would be better. But now I would like to share with you this case. In terms of dimension of defect, this case is similar with the previous. Horizontal bone defect. But now we are speaking of horizontal bone defect in lower jaw. We said from this morning, which is the difficulty to activate the regeneration of the bone in the lower jaw. So in any case, I prepared the case, removed the tooth, removed the included tooth, premolar tooth. I waited for the healing, 3 months from the extraction of the teeth, and these were the CBCT slice. The X-ray post-healing. This is the healing of the soft tissue, 3 months later. We perform the same design, starting from the reticular pad, involving 2 teeth around the last 2 teeth near the defect. So detach perfectly the lingual and the backup flap, place in evidence the metal nerve, all steps of the surgery. And this is the clinical aspect of the bone. Horizontal bone defect. But look at the characteristic of this bone. Very hard, very white, no bleeding. I can tell you, poor cancellous bone. So non-ideal condition for the bone regeneration. But technically, everything were done perfectly. Perforation of the bone, harvesting of the bone, mix of the bone with xenograph material, passivation of the flap, fixing of the membrane on the buccal side and the lingual side, pushing of the biomaterial from the lateral access, everything were done correctly. Close the membrane perfectly over the top of the biomaterial. Close the flaps according to the protocol. 2 lines of suture. Horizontal matrix sutures plus interrupted sutures. I waited. 6 months post GBR. I didn't have any type of complication. Everything went according to the ideal protocol. No complication, no exposure, nothing was incorrect. Apparently the bone is good in X-ray, but in CBCT, oh my God, good. Do you agree? Good quantity of bone is apparently well compacted the bone. I was very happy. Oh, with absorbable membrane, good results. Ooh, Marco Ronda, bravo. I planned the project, and this is the day of the implant insertion. Open the flaps. But before to open the flaps, I would like to show you a thing. With absorbable membrane, I didn't manage to regenerate vertically 8 millimeters. We can regenerate the bone horizontally, but not vertically. So, but this is a elderly patient that did not suffer, was able to suffer. Some pathologies, the A, no, Marco, please, place my teeth without longer treatment. Okay, absorbable membrane, very simple. I didn't need to increase the verticality. I knew that probably the crown would be longer than the adjacent teeth, but patient told me, but need the teeth. My life is short. It's not important to have this teeth for years. I need the teeth now, not in 2 years, in long time. I accept. But look at the quality of bone. Horrible. Horrible. The biomaterial was partially integrated inside of the flap. The bone that we saw with the CBCT was the fibrointegration of the biomaterial, not the presence of osteoid tissues. We lost the barrier effect before that the biomaterial was organized in osteoid tissue. Only the osteoid tissue can protect itself from the competition of the connective tissue. But if we didn't manage to get osteoid tissue, the biomaterial, when we lose the barrier effect, is invaded from the connective tissue with the fibrin infiltration. And when I elevated the flap, part of the biomaterial was inside the flap, no bone. And you can see the part of bone that remain is not well compacted. There are a lot of granules that are moving around the mounts. But I waited 6 months for this regeneration. Also this regeneration is shift. So it depends not from the protocol, not from the surgical procedure, not from the biomaterials. It depends from the choice of barrier. This is the reason why I can understand that you are worried relating the using of non-absorbable titanium reinforced membrane. It is correct, because if you should do a little mistake, you can fail. And so, the conceptualization, the knowing of these difficulties in the using of the non-absorbable titanium reinforced membrane elevate your responsibilities in the treatment of your patients. Good. But it is true on the one side that is more difficult, but you have to learn. Because if you wanted to regenerate the bone correctly, you cannot avoid to use the correct device. And my presentation has been concentrated on this concept. Technical point of view, I am sure that tomorrow you will remember this, my consideration. Technical point of view and biological point of view. This is the condition in order to choose correctly the barriers. And the reason of our failure is that the hard bone, poor vascularization, limited the quota of cancellous bone. In the lower jaw, it's very difficult to get a good quality of bone regeneration using absorbable membrane. And then another thing, the patient, elderly, please, Marco, don't graft the gingival graft from part. I can understand. It was very hard. And I tried to manage the soft tissues without free gingival graft, using the modest quantity of tissue with a strategical way to sutures. I don't have time in order to share, but a strategical, it's a normal sutures, but it's not a normal sutures, it's invented the sutures. And I managed to double the quantity of keratinized tissue band from here to here, but I didn't manage to restore the depth of the fornix. Probably I define an adequate seal with just sufficient keratinized tissue band, but I didn't restore the depth of the fornix. And for the patient, it's very difficult to clean. I didn't offer to the patient the possibility to maintain a good health around the implants, because for him the cleaning is very difficult. So when we to treat these cases for which the time of bone regeneration is long, the time of revascularization is long, very long, we cannot use an absorbable membrane. We have to use an non-absorbable membrane. The time of barrier effect depends on the time of maintenance of the barrier. Now we work with the dense Teflon, PTFE dense. It has some advantages, like unlimited barrier effect, plastic and easily adaptable to the defect, easily removable. Dense Teflon could provide a barrier to bacteria in case of early exposure of the barrier. But it has also some disadvantages. It has to be confirmed to the defect directly during the surgery. No precision, long time. Then it is true that it has inside the titanium, but the space-making action is therefore limited, because the rigidity of the titanium is modest. And then it is very difficult using of this barrier when in order to cover the defect we need more devices, more barrier, and we have to overlapping 1, 2, 3 barriers, and in this case it's very difficult to organize this puzzle. And then we have to fix the barrier on both sides, buccally but also limbally. And then we will see after this device that another device can be fixed only on one side. And then it is difficulty shaping on the defect in curve, especially in the premaxilla, because the membrane is square, the titanium is placed square, but we have to create a rounded shape. It's very difficult. And the last one, the complete impermeability that is underlined as advantages from the company, because the company says My barrier, PDFE dense, with its impermeability, in case that it should be exposed early, the impermeability can protect the regenerated area from the contamination of the bacteria. Is it true? So and so. We could speak one day related this kind of complication, but I can say you that I can tell you that it's very difficult to save a surgery of GBR in case of early exposure of the membrane, even if the membrane is in PTFE dense. A classic one-stage case of periplatitis, removal of the implants, CBCT, and very severe contraction of the residual bone. We perform a one-stage approach, shape the membrane on the lingual side, clean the surface, the inner surface of the membrane, the bone, the implants, the graft, the biomaterial, 12 millimeters of verticality. It was the time in which I had the possibility to use a allograft material. I don't know if in your country here you can use allograft material. Yes? Now in Italy it's not possible. A lobby, classic lobby, between the tissue bank determine influence in the material law for which we cannot use allograft material. This was the time in which I used Puros. Puros is a product produced from Zigbee, but in the same way I use a different allograft material, Botis or Encore from Osteogenic, so different companies, and the characteristic of the bone was similar, the allograft material was similar. A mix between the allograft material and autogenous bone, the closure of the membrane over the top, 12 millimeters of horizontality always, and then from here, very big defect, we arrive to here. We reconstruct completely the verticality. After the periplatitis, if we place an implant with 10-12 millimeters length, we lose 10-12 millimeters of alveolar bone. Why? It's very simple. Because the patient arriving in your practice, your patient, not the patient of another colleague. Everybody have periplatitis, me and you, okay? Your patient come back in your practice and you control with the X-ray. Oh my God, periplatitis. And the patient follow closely the oral hygiene, the professional oral hygiene, everything. But sometimes you know that even if everything is done correctly, surgically, and in a maintenance way, sometimes the periplatitis grows. And so you try to clean. First, you send your patient for the hygienist. Please clean very well. but the periplantitis ingrows. Try to open a little flap. Sometimes you try to place little material, but you cannot save the implants if you don't perform a correct protocol. The correct protocol is the removal of the prosthesis, the opening of the flap, the decontamination of the implant, the passivation of the flaps, the placing of the membrane in occlusal way, and the closure for the first intention, not around the healing abutment. The first intention. Then you have to wait for the bone regeneration, then you have uncovered the implants, you have to promote the periosteal contact, and then you have to treat again the soft tissue with the soft tissue management. In this way you can save differently the periplantitis continues. 1 millimeters, 1 millimeters. And then arrived the day in which your patients call you, "Doctor, sorry, but do you remember my case of periplantitis? I have an abscess." Oh my God. And tried to take antibiotics. Then come in my practice on 1 week, because the abscess cold, and you can note that the bone reduced. Now the pocket around the implant is high. And so you say to the patient, "Dear," 1 second, now I have to, "Dear Min Nguyen Kwon, I have to remove the implants because I cannot say you had already had an abscess, and this condition probably will continue in the future, and we destroyed always a new bone. I have to remove. But until that time, the patient has the fixed teeth. Because you know that also for 1 or 2 millimeters, the implants are stable. And so you told to the patient, "I have to remove the implant." And the patient that trusts in you says, "Yes, doctor, you can remove mine, but then I want again the fixed implants." But you are not able to regenerate the bone. Because we are speaking of vertical bone regeneration. And you say to the patient, Mr. I don't remember, Min Nguyen Kwon, I cannot place new implants because I don't sufficient bone. And the patient tell you, "So doctor, in this case I would like to maintain my implants, and sometimes I can take antibiotic. And this is the reason why the bone absorbs, and creates a disaster." All cases of periplantitis needs a severe vertical bone regeneration, because the patients may maintain the implants until that they start be mobilized. And from here, you arrive here. Oh, bone, an incredible multiple bone. Bone, 12 millimeters in verticality, 14 millimeters in horizontality. more than 12 verticality, because I submerged the last implant for 2 millimeters, 40 millimeters in verticality. And this is the why of the region. Wow. Incredible quantity of bone. From here to here. Latin way, restitutium ad integrum. It means that I restore the initial condition as the nature had. Restitutium ad integrum. The dimension of the crown is the same of the adjacent tooth. The perfect restoring of the depths of the fornix. A good quantity and stable quantity of the keratinized tissue band around the implants. It doesn't mean that in this case I cannot have perimplantitis. It doesn't mean. But I reduce the risk of perimplantitis. From here to here. After the progressive load, when the progressive loads were completed, this is the quality of bone that we got. You don't manage to distinguish the difference between the regenerated bone and the native bone. All material has been substituted by the new bone. Do you remember the histologist that I showed before the lunch? Periosteum contact, bone maturation, completion of the substitution of the material. Six years later, the bone is stable, a minimal contraction on the crestal side, but the bone is stable. 2 stages. Another approach, always with a non-absorbable titanium reinforced membrane, that showed how, with this kind of device, in a specific case like this, the modeling and adaptation and fixation of membrane is very complicated. This is a case in which the atrophy was very severe. I perform an linear, unique and crystal incision, 2 distal release incision posteriorly, and then the perfect passivation of the flaps. What is this image? Do you manage to understand? This one is the right buccal flap and the left buccal flap that are closed in the middle of the mouth. This is the passivation of the flap. 5 centimeters of buccal flap passivation on each side. If you want to protect the new bone volume, considering that the palatal flap cannot be moved, you have to gain this quantity of tissue. And behind the tweezer, here there is a suture that is keeping jointed between them two palatal flaps. Palatal flap open, palatal flap open, close with these sutures, and this tweezer backup flap passivated closes over the top of the ring. A good passivation. So, on average, 3 centimeters and a half from each one in order to arrive in this way in the middle. We regenerated the ridge on the right and on the left. Double membrane on this side and single membrane on the other side. Closure of the membrane in order to reconstruct completely, but I can tell you that it's very difficult. And just in this case, if I remember correctly, considering that I love transfer my knowledge to my colleagues and to educate my colleagues in order that they can reply my procedure, I said, a case like this cannot be treated from a student, my student. It's too complicated. Because in order to fix and shape the membrane, I place something that cannot be transferred in the education. It's something that is my feeling, that I gain a long career. Because it's too complicated. Adapt the membrane in this way. And so then I found a solution in order to transfer this hypothetical procedure also to my students. So I closed perfectly the flaps, and during this surgery step, I activated 3 implants that I placed at the time of double sinus floor elevation. The surgical procedure is divided in this time. T0, time 0, double floor elevation, double sinus floor elevation, plus 3 strategical implants. Tuberosity on the left, tuberosity on the right, and in the middle of the palatal sutures. The second stage, the GBR, after 5 months, is the regeneration of the complete upper jaw, plus the activation of the implants, in order to create a stable support for the temporary restoration. And this is the temporary restoration. 3 locators that place on the strategical implants with the mobile prosthesis that doesn't touch or is in contact with the ridge, with the mucosa. And then the months after the completion of the GBR, I remove the membrane. This was the volume that I got. The regeneration of obtain enormous quantity of bone in verticality and in horizontality. The placing of the implants, and the closure of the flaps. Then I waited for the maturation of the bone and naturally the integration of the implants, and this is the time of the soft tissue management. I did a keratinized tissue band. I lost completely the fornix, and so I performed a translated pedicular flap, and a surgical procedure that is performed elevating a half thickness strand from the palatal and moving keratinized tissue band and the alveolar mucosa buccally in order to increase the missing keratinized tissue band and to increase the depth of the fornix. And this is the quota of keratinized tissue band that we got. And in a patient in which the quantity of bone was very limited, we managed to place 10 implants in order to support the skeletal processes, fixed skeletal processes, but with a lot of difficulties, because the adaptation of the membrane, the stabilization of the membrane is very complicated. But this kind of procedure sometimes doesn't work. The non-absorbable titanium reinforced membrane has a limited space making action. This is an interesting case, a double case of bone regeneration in the same patient. On the right, in which I place and narrow implants has a distance screws. It was the time in which I analyzed the biology of the contact between the implants and the regenerated bone, as I showed before. And so I placed these distant implants, 16 millimeters of implants, fixed in 2 millimeters. It means that it sticks out of 40 millimeters, 1 centimeter and up. I grafted the biomaterial, big quantity, and I closed the membrane. On the other side, same patient, I performed the same procedure, but without the distant screws, without the distant implant. I grafted the biomaterial, closed the membrane. 1 centimeter and half of horizontality. The surgery went very well. On the right, on the left. Flaps perfectly closed, non-infection, perfect. Okay. In my mind, I thought, oh my God, I believe that below the membrane, I will find a fantastic bone. Everything was good, the ridge perfect. And this is the first image. Incredible. The patient bite such strongly on the ridge that destroyed the titanium. Destroyed the titanium. This is the titanium that broke the portion of the titanium that go from the liver to the bottom, open, and the implant stick out. The flap were perfect, strong, very thick, good quality of sutures, two flaps in contact, but this is the consequence of the biting from the patient side, because we don't manage to guarantee an adequate space-making action. And so, this was the situation before. And look at the titanium that's broken. And the top of the ridge was flat. I didn't manage to regenerate verticality, but probably I had 2 centimeters in horizontality. Push it. Push it. But then I open on the other side. The behavior of this patient was the similar. And on the other side, you can see that also on the other region, the regeneration is flat. The shape of the membrane has been modified. Now it's larger than the original. In fact, also here, probably we have 2 centimeters in horizontality, no verticality. So, this case is useful in order to understand that when we have to regenerate a severe defect in the posterior lower jaw, probably we have to use a different device. Sometimes we can obtain good results, but in other cases, the limited space-making action of the titanium reinforced membrane could cause this kind of problems. And so, in alternative, which is the device that we can use? We said that the non-absorbable titanium reinforced membrane is indicated for all cases in which the angiogenesis time is very long. But when the defect is very extensive, we have the capacity from the barrier to have an unlimited time of barrier, and this is good. But the space-making action is limited. And so, the alternative, which is, the alternatives could be this one. The customized titanium mesh that has the ideal space-making action, but the barrier effect is limited. Oh my God. We don't have the ideal condition. And this was the product that was presented in the world from the company. If you wanted something of strong, with a good space-making action, but you have to take this characteristic, big holes. But I didn't want the big holes. Because with the big holes, I have the same problem of the using of absorbable membrane in the big defect. The barrier effect is shorter than the time of regeneration. And so, I wanted a customized titanium device with a high space-making action, but with a longer barrier effect time. And there wasn't, and so I decided to produce by myself. Not by myself. I asked some to some company, please, would you like to follow me in my project? No, I don't trust in it. Okay. Do you want to follow me in a project? No. The non-absorbable memory will be used for the futures. I am not sure. Yeah, we are sure. Okay. Do you want to help you? Yes. And so I found the company that was the leader in the production of the customized titanium meshes, the RIOS. And this company offered me all know-how related to my project. In 2017, I used the first prototype of this device with incredible results. And then I modify. It's normal, it was a project in development. And now is used in all parts of the world, and all companies are trying to copy, but they don't have the specific technology or the capacity of use the laser melt technology. And so, this is the new generation of customized titanium mesh. They are represented by a micro-perforated weighting, which prevents it from being incorporated by the connective tissue. It develops an effective barrier to connective tissue, but not being totally occlusive. It allows the exchange of fluids and the osteogenic action of the periosteum. It's a balance between big holes and occlusive surface like the PTFE dance. I didn't like PTFE dance, even if I am using, but under the biological point of view, they have a limitation. We don't have a perfusion of the blood through the porosity, because it has a porosity. And at the same time, the big holes was a great opportunity for the vascularization, but also for the competition from the connective tissue of the environment to be regenerated. And I wanted to find a balance in which I could have a fluid passage and vascularization, but with the isolation of the connective tissue. And so, now we can do the break. 1 second. And so, these were the advantages of the old customized titanium meshes. It does not have to be confirmed during the surgical phase. Very easy. Place immediately. You don't have to adapt anything, because it is already prepared for the defect. A complete space-making effect in all conditions are reached. Even if the patient should bite on the gum against the mesh is rigid. We don't have any modification in its shape. It can be fixed only one side of the defect. Do you remember that before I spoke related the PTFE dance that had to be fixed on both sides, buccally and lingually. Instead, this device is such precise on the defect that is sufficient only to screw on the buccal side. And then it can be easily customized on curved bone defect in the anterior zone. Differently, the PTFE dance is very difficult in the shaping of curved area. And then it can be customized for each severe and extended bone defect with only one piece. And we don't have to do the puzzle of barrier. But it has some disadvantages. We are speaking of the old customized titanium mesh. It has no barrier effect. It needed to be protected by an absorbable membrane. Barrier effect too short compared to the time of new bone formation. Its removal is often complicated by the invagination of the connective tissue in the large holes. Because before to get in the osteoid tissue, the barrier effect disappears and the connective tissue penetrates inside. And when you have to remove them, the connective tissue is inside. You have to cut with a blade, very, very difficult. And then the reduction of the bone, partial bone regeneration, presence of the connective layer under the mesh. But these advantages are the same for the new generation of customized titanium meshes. But then we have other advantages, not disadvantages. Other advantages. Easily removable due to the presence of the cracker line. Is another my invention. But I remember the day that I had this illumination. I had, honestly, a cracker in my hands. I had a cracker, real cracker. And why I broke the cracker perfectly in the cracker line, I had an illumination. Oh my God. But if I create the same cracker line in my mesh, the removal will be very easy. I don't need to cut, to use the board. No, I have to move the border and crack. And so I introduce the cracker line. Then, barrier effect enhanced by the fine mesh that simulates non-absorbable membrane, but with the efficient capillarity of expanded T-teflon. I am looking at a lot of young colleagues. Probably more of you don't know the PTFE expanse, the Gore-Tex membrane, that had a different porosity between 5 and 30 microns. Now the PTFE dense has 0.3 microns. But with the old membrane, it was true that in case of early exposure, it was a disaster, because the bacteria could penetrate inside of the regenerated area and contaminate everything. But when your surgery was performed correctly with the closure of the flaps, the quality of bone was completely different from the actual membrane. Because this porosity allows to the vessels that came from the flaps to penetrate inside of the regenerated area and to get an improving of the quality of bone. And then we have the total bone regeneration. There is never any competition between hard and soft tissue. Where can we apply this device? After the break.